Hello, everyone. Thank you so much for joining us today for the second event in the Recovery Science series. Today, the topic is understanding, addressing substance use disorder stigma in clinical care settings. So as everyone is kind of filing into the Zoom room, we're going to start with a poll. So I'm going to keep this poll up for about a minute, and please fill it out. We just want to get a sense of who is in attendance today, kind of your own professional roles, and then your academic backgrounds. So we'll keep that up for about a minute. And then we'll have a second question for you right after. All right, welcome everyone to everybody who is just now joining us. We have a poll up for you. We're asking about your professional and academic backgrounds today, just so we can get a sense of who's in attendance. All right. Okay, we'll keep it up for a couple more seconds and then I'll start the second poll. We're looking pretty good on numbers. All right, okay, I'm gonna start the second poll for us. So now we have a question for you on your knowledge and perspective on stigma. So the question is, what do you think is the best way to address stigma and discrimination against people with substance use disorders? All right, welcome everyone who's just joining us. We have a poll active for you. It's going to be active for about a minute, and we just want to get a sense of kind of your perspective on the best way to address stigma and discrimination against people with substance use disorders. All right, okay, our numbers are looking good. We'll keep the poll up for about 10 more seconds. So if you haven't already, please respond to the poll. All right, amazing. Thank you so much, everyone, for participating. We're going to close the poll now. All right, amazing. Okay, thank you so much, everybody, for joining us for the second event in the Recovery Science series. I am delighted today to introduce Dr. John Kelly. Dr. John Kelly is the Elizabeth R. Spallin Professor of Psychiatry and Addiction Medicine at Harvard Medical School, the first endowed professor in addiction medicine at Harvard. He is also the founder and director of the Recovery Research Institute at Massachusetts General Hospital, the associate director of the Center for Addiction Medicine, and also the program director of Addiction Recovery Management Service. Dr. Kelly is a former president of the American Psychological Association's Society of Addiction Psychology and is a fellow of the APA and a diplomate of the American Board of Professional Psychology. He served as a consultant to US federal agencies and non-federal institutions, as well as foreign governments and the United Nations. His clinical work and research work has focused on addiction treatment and the recovery process, mechanisms of behavior change, and reducing stigma and discrimination among people suffering from addiction. So without further ado, I am delighted to introduce Dr. John Kelly, who will be talking about addressing SUD stigma in clinical care settings today. All right.
Thanks, Ting Yi. Thanks so much, Ting Yi, for the nice introduction. Welcome, everybody. So glad you're here. I'm going to share my screen. Hopefully you can all see that okay and hear me okay. Fantastic. Thank you. Thanks for joining. I hope this is informative, interesting at least, if not helpful to you in your work, in what you do, and in your lives with others. You know, when we're talking about addiction, of course, it runs, you know, in parallel and is really couched in stigma and discrimination. And the question is, how do we address it? You know, how can we address these perennial problems pertaining to addiction, substance use disorders, and people who suffer from them? And that's really the focus of today. And what can we do clinically in clinical settings to help minimize the effect and impact of stigma and discrimination? I'm coming to you today actually as part of an initiative through SAMHSA and the AAAP called the Opioid Response Network. And this is a national enterprise SAMHSA sponsored. The great thing to know about this is that if you are a provider or an agency out there around the country, you can obtain free assistance and training, technical support and training to address opioid and stimulant and other substance use disorders through this initiative. And you can get technical assistance from experts free of charge. Here's the website if you want to look it up, if you want to get any aspect of training and expertise in these areas for yourself, for colleagues, for your staff. Please make use of this free federally funded resource. And just to let you know, I don't have any conflicts, and what I have to say today is down to me, for better or worse. I do want to let you know that we have this Recovery Research Institute that Ting Yi mentioned. We publish a free monthly bulletin. Every month you can sign up for it at recoveryanswers.org. And what it does is, we just released our June issue yesterday. It translates and the latest science on treatment and recovery. And we get a lot of good feedback on its utility. Please make use of it. It's a freebie. And we summarize about 7 to 10 recent studies pertaining to treatment and recovery that may be useful to you in your practice or in your lives. So on to the content today. I, just been reflecting, zooming out about where we've come in the last 50 years. Why is that important? Because actually 2020 marked the 50th year milestone of the declaration of the war on drugs under Nixon. And so I've just been thinking about that, looking at how far have we come in the last 50 years? What have we learned? And where are we in terms of substance use disorder, addiction, and stigma and discrimination in relation to that? Well, you all know, or you can find out on YouTube, you can see videos of Nixon declaring the war on drugs. And he famously declared drug abuse, quote unquote, drug abuse, as public enemy #1. Now, just reflecting on the rhetoric of the war on drugs and the change, the shifts that I see have happened over the last 50 years. I think one thing that's happened is our change in rhetoric, and that reflects and affects our approach to these endemic problems. I don't think today many people would say it's public enemy #1, but rather that is our top public health problem. And that's an important shift in emphasis and rhetoric. And it's reflected also in the legislation that's been passed over the last 50 years. Initially, in the 70s and 80s, we saw legislation pass which had punitive, was more of a punitive, tough on crime approach, which saw prison building industry exponentially increasing incarceration, particularly among minority persons, and tough on crime approaches with mandatory minimum sentences for drug possession. Contrast that with the last 20 to 30 years, which has emphasized access to treatment, paying for treatment, making sure that people can get treatment for substance use disorder. So it's that shift in legislation also. Back in 2013, under the Obama administration, there was an official shift at the national level, which marked a shift away from the tough on crime approaches of the war on drugs towards a broader public health approach. And this was declared on December 9th, 2013. And I had the privilege of being there presenting some of the data that I'm going to present to you today. Not only that, we've seen the failure of criminal justice approaches in addressing endemic addiction problems. We've had this movement away from purely punitive approaches towards realizing where, to the extent that addiction is driving the crime, if we can address the core drivers of the crime, we can hopefully reduce criminal activity as well. And so there's been the birth of drug courts, not only in the criminal justice system, but at the law enforcement level, front line itself. We've seen now changes, shifts in attitudes and practice. Started right here in Massachusetts, in Gloucester. Some of you know Chief Campanello, who started this ANGEL program, Help Not Handcuffs, advocating for people with addiction problems to come to the police station, not to get arrested, but to get into treatment. That police would actually do the job of public health practitioners to actually address what they saw was a failure of their own activity to address these endemic problems. I was speaking last January in Vienna at the United Nations. This is a global phenomenon, addressing stigma, discrimination, and malpractice and different ways, poor ways of addressing these problems worldwide. Came outside. This is the only notable monument outside the United Nations building in Vienna. And it says here, you can see on the right-hand side, it says dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. Again, this is outside the United Nations in Vienna. So there is a global shift, of course, happening, not just a national shift that's happened in the last 50 years towards broader public health emphases and approaches, which, as I'll talk about, it's really come from our understanding over the last 50 years. Based on the science that has come out of principally funded by our federal agencies in the United States, in terms of NIDA and NIAAA in particular, who have funded 90% of the world's research and continue to do so on addiction. And we've learned a lot as a result of all the research that's happened in the last 50 years. This research has helped our understanding in terms of the causes and the impact of substance use in the brain and what it does to the central nervous system, and also the causes. We've learned a great deal in the last 50 years, and this has all helped with stigma and discrimination. We've learned a lot about the causes of addiction, the fact that it's multifactorial, that there are genetic components, things we didn't know 50 years ago, about its impact in the brain, the risk factors in the population, which elevate or decrease risk for onset of substance use disorders, different pathways into and out of substance use disorders, the clinical course, and different treatments that have really come about as a result of what we've learned. We know now that roughly half the risk for addiction is conferred by genetics, things we did not know 50 years ago when the declaration of war on drugs was declared. Through dozens now of studies, we know that this to be true, that just like other complex disorders, psychiatric and medical disorders, that substance use disorder is an interplay of biology, genetics, and the environment through the life course that can have the environmental effects, can have epigenetic effects, which can turn on genes that would not be turned on otherwise. We also know that and have gotten a lot clearer on the impact of substance use and chronic exposure to substances in the central nervous system in the brain. We understand now that the brain changes as a function of our activity, our environment, and exposure to drugs. And we can see radical changes, radical effects through neuroimaging, both functionally and structurally, on how exposure to substances and other addictive behaviors, behavioral addictions, can also change the structure and function of the brain. Now, clinically, of course, we've seen lots of things happen, right? Not just at the genetic and neurobiological level, but at the clinical level. The stages of change in the 1980s, which led to motivational interviewing. The idea that what people with addiction need is not a good talking to, but a good listening to. We've had shifts in our understanding about the need to not just treat and stabilize people, but to prevent relapse. And cognitive behavioral treatments have come along as very important underpinnings of most of the treatment that is provided, that has a sound, rational, theoretical basis and strong strategies to help people achieve and maintain remission. Contingency management. Hundreds of studies have shown that the positive aspects of providing positive reinforcement can help shape activity and behavior to help people stabilize in remission. Very effective medications. We've seen this particularly importantly implemented in terms of opioid overdose, with agonist therapies as well as extended release antagonists, as well as FDA-approved medications for alcohol addiction. Harm reduction strategies, of course, have become incredibly important when we're talking about infectious disease transmission, as well as overdose. And these have been critically important in light of the recent epidemic of opioid overdoses. We've also seen the recognition of the importance of long-term disease management, not for everybody, but for people with the most severe conditions, the kind of folks that we see in specialty treatment settings. And in part, the reason why there's been this emphasis on chronic disease management or recovery management is because of typically the nature of substance use disorders and its chronic course. I think what's important here when we think about stigma and discrimination is that stigma and discrimination interacts at all of these levels in terms of seeking treatment, the delay in seeking treatment, which can take 4 to 5 years after people meet criteria for a substance use disorder. It can take them many years to acknowledge that, to admit that to themselves because of stigma, public stigma, internalized stigma, as well as to stay in treatment when they start seeking treatment. Family members also are susceptible to these biases, to the stigma and discrimination that they feel too when a loved one is suffering from substance use disorder. And this can prolong treatment and can lead to early termination from treatment as well as delay in treatment seeking. What's also noteworthy here on the right-hand side is that in terms of the chronicity, is that it can take 4 to 5 years, even after people achieve that first year of full sustained remission, which in and of itself can take a number of years to achieve for people after they start to seek help. It can take 4 to 5 years of continuous remission before the risk of meeting criteria for a substance use disorder in the following year drops below 15%. Why 15%? 15% is the annual rate in the general population of meeting criteria for a substance use disorder. So to be no more likely than anybody else in the general population to meet criteria for a substance use disorder in the following year, if you've already had it, takes 4 to 5 years of continuous remission. So risk for reinstatement of the disorder is elevated even after people achieve that first year of sustained remission. And this just points out that stigma and discrimination operate at all these levels in terms of influencing the likelihood that someone will seek help sooner, stay in treatment, as well as recovery sooner. Can we speed this up? Is this an inexorable clinical course of this illness, or is it the things that we can do to speed up time to accessing treatment and help, having a shorter clinical course of the illness after beginning treatment, and also to achieve remission and stable remission sooner? I often use this analogy, this metaphor of a burning building, because I think we've recognized there's a crisis. The building is on fire. The person's life is out of control, oftentimes with people with severe substance use disorder that we see in specialty care. We've done a good job in the last 50 years, I would argue, of finding treatments that can provide stabilization, metabolic stabilization, and safety, comfortable withdrawal, medication, and short-term acute care treatment. Most of our treatments have been tested over 12 weeks, not even 12 months, but 12 weeks of acute care stabilization and treatment. Now, most of us think these days of addiction being a chronic condition, which is susceptible to relapse, as I've just outlined. Where I think we have perhaps been remiss is, while recognizing that we need to put the fire out, we have done less good job at providing the building materials that people need to rebuild their lives, so-called recovery capital or recovery resources, the social determinants of health, which can help mitigate the allostatic load, the biobehavioral stress that so many people early on in recovery suffer from. As well as, very importantly, I think, again, this is related to stigma and discrimination, is the building permits that people need to start rebuilding their life. If we don't provide or cannot provide a building permit that allows people to get a job, to get housing, to get a loan, to get back into school, how difficult is that for somebody who's already climbing up a very steep hill to burden them, to shut the doors, that because of a prior criminal conviction, that they cannot access these things, which are so vital, so demoralizing to have those doors shut to you because of prior criminal convictions related to substance use. So this is something I think we need to change. So just zooming out there, look, we've come a long way. We've learned a lot about the causes, the impacts of substance use. We've learned that it's multifactorial, that is a genetic component like other complex illnesses. We've learned that it's an impact, that it changes the brain, the structure and function of the brain very radically, actually, with people who have more severe problems. But despite all of this knowledge, we know that stigma still persists and discrimination against people with SUD, and not just active, but in recovery, and notably in clinical settings. So what is the nature of stigma and discrimination? What is its impact, and what can we do to address it? Well, a definition of stigma is an attribute, behavior, or condition that is socially discrediting. What is discrimination? Discrimination is the unfair treatment of individuals with that particular stigmatized condition. So I think it's helpful to distinguish between stigma, the actual condition, and then the unjust treatment of people who have the condition. And that comes into play, of course, in our overall policy approaches, as well as clinical approaches at the front line of treatment and in medical settings more broadly defined. It can have influence, of course, because it can determine the way that we view these problems, can determine how we address them as a society, where we're going to put our emphasis. As I mentioned, the war on drugs was really about the hope that a punitive threat would deter enough people from ever trying drugs that we would eradicate the problem. Yes, it does for some, but it has not been an overall effective approach. And we need a broader approach. And this is what has been discovered and realized more recently. Not just in terms of public stigma, but personal stigma, of course, is that people internalize the stigma. And that can, as I've mentioned, it can lead to shame, guilt, an unwillingness to talk about their problems, an unwillingness to admit it to themselves, which can delay help seeking. And typically, what have we done in our society is to wait too late. Is we wait till people have stage 3, stage 4 addiction before we can see it, before we can do something about it, instead of intervening earlier. This is important to know that there are different dimensions of stigma. Stigma is not one thing, but rather there are multiple dimensions. One, of course, is blame and responsibility, and I'll talk about this in more detail. Are they responsible for causing their problem or condition? Can they recover is another dimension. Can people actually get well from their condition? Can they remit and live and function normally in society? Are they therefore dangerous? Are they dangerous, and should they be socially excluded because of that unpredictability, volatility, and perceived danger? So these are commonly studied dimensions of stigma regarding different social problems, including mental illness and addiction. Now, we do know from lots and lots of studies that have been done that substance use disorders are possibly, maybe probably, the most stigmatized conditions nationally and internationally. This was a study done a few years ago now in 14 different countries on 18 of the most stigmatized conditions in those societies. This included being a criminal, being HIV positive, having AIDS, as well as being addicted to illicit drugs or licit drugs, alcohol. Number one, universally across these 14 different countries, illicit drug addiction was the number one most stigmatized problem. Number 4 was alcohol addiction. Less stigmatized probably because it's legal. We also know from dozens and dozens of studies that SUD, substance use disorder, is more stigmatized than any other psychiatric condition. In part, I think that's because people with substance use disorder are viewed as more to blame for having their condition than other psychiatric illnesses, in part because you have to take something from outside of yourself and take it into yourself, and there is a relief and pleasure associated with doing that. And I'll talk more about that. Now, describing substance use disorder as treatable tends to reduce these elements of stigma. And people who have these stigmatizing beliefs themselves, irrespective of how severely addicted they are, are less likely to seek treatment if they hold that internalizing stigmatizing beliefs. And I think importantly, from a clinical perspective, is that clinicians themselves are like other people. They hold stigmatizing biases as well. But one thing that can help clinicians is more education around the nature of substance use disorders. So I've alluded to this a little bit. Why is addiction and substance use disorder so stigmatized compared to other social problems and health conditions and other mental illnesses? Well, I think it has, as I've alluded to, these elements of control, cause, and controllability. And I think because substance use disorders are caused, of course, by the introduction of an external substance into the body and into the brain, that this involves volition initially. People have to choose and they decide to take it. They don't know, of course, that they are more or less susceptible at the time that they are introduced to the substance. Take alcohol. 90% of people are introduced to alcohol at some point in their lives in the United States, but only 15% will become addicted. They don't know who they are at the time they're introduced, but they notice they get this positive response, maybe a much richer, deeper response than people who don't have that genetic predisposition have. So these two dimensions of cause and controllability, I think, are primary drivers of stigma. If we can say that it's not their fault and they can't help it, stigma tends to decrease. We tend to have more compassion. If we say, wait a minute, it is their fault and they really can help it, they're just engaging in volitional, willful misconduct, then stigma tends to increase. And this just shows that relationship. Now, in terms of cause, these two dimensions, cause and controllability, we've learned from the last 50 years of research that just like other complex illnesses, certain people are more susceptible by virtue of their DNA than other people who don't have that susceptibility. So availability, accessibility, susceptibility are key factors in contracting onset of substance use disorders. We know that about half the risk for addiction is conferred by genetics. So this has helped us understand the nature of the cause and susceptibility to substance use disorders. We've known for a long time that it runs in families. So there are environmental and genetic components which contribute to elevated risk. In terms of controllability, that other dimension, cause and controllability. Now, we've learned, as I mentioned, about neuroplasticity, neurotoxicity, how the brain is affected, how it tries to adapt to this abnormally high level of reinforcement by virtue of exposure to these powerful substances, that it tries to adapt, and those adaptations become maladaptive over time as the brain tries to adapt to stronger and stronger doses. The other thing is neurotoxicity, is that certain substances will kill brain cells and change the structure of the brain. You don't have to look very long or very hard here on the bottom right to see that the structure of someone chronically exposed to heavy doses of alcohol produces structural changes in the brain, not just functional ones. If we were looking at, if I told you that was a cancer image, you'd say, of course, cancer would affect that. I don't think we would always quickly think that the exposure to a substance could radically change tissue in that way, but it can and does. And this helps us to understand, why is it that someone who has this strong impulse to stop substance use, they want to stop, they swear off it, but they break that promise to themselves and to other people. When we see images like this now, it helps us to understand what's going on, that there is a medical malfunction that happens in the brain that inhibits, that impairs that desire to inhibit that prepotent impulse to use a substance. The good news is, of course, is that with treatment and abstinence, people's brains can change. And we know that can take a little while, but medications, psychosocial treatments, therapeutic environments, all can help foster and create an environment that Mother Nature can do her work, and the brain can recover. Not everything, but it can recover. And we see recoveries, of course, millions, tens of millions of recoveries from substance use disorder around the country. So we've learned a lot about cause and controllability in the last 50 years, but still stigma persists. Now, what does help is education. So educating people about this can really help diminish stigma. So they start to understand about the nature, just like other things throughout history. As we've come to understand their nature, we've started to decrease these negative judgments towards people who have these conditions. Another major way that stigma and discrimination can be reduced is through personal exposure. We are surrounded by tens of millions of people in recovery, and we don't know it. So now there's a big movement, of course, faces and voices, putting a face and a voice on recovery, to speak out. Not everybody does it, but many people have decided to do that, to speak out, to come out and talk about their recovery, to help dismantle these stereotypes and disabuse people of those stereotype beliefs that we can hold towards people with addiction. Another way is through shifting our language and terminology. Why is that important? Because our language both reflects and affects our approaches and our conceptualization of these approaches. Now, it's not as straightforward as I would like to tell you regarding this issue of education and the biological and biomedical emphasis. Now, I've been talking quite a bit about genetics and neuroplasticity and the neurotoxic effects of exposure to substances on the brain. So if we actually were to emphasize all of this and say, look, yes, this is a brain disease, this is genetic, this is a brain disease, we emphasize that, what happens? Would we reduce stigma across the board? Well, that was the hope. Of course, that's the hope of federal agencies and different people, where different treatment settings, we often emphasize these aspects, as I'm doing today. But what do we know about the impact of that? Well, it turns out it's good news and bad news. In some ways, that biomedical emphasis can reduce stigma, but not all types of stigma. So when they have looked, for example, in the mental health field outside of substance use disorders, they have found that emphasizing the biogenetic aspects, causes of mental illness, actually has a positive effect on reducing blame towards people who suffer from mental illness, but has the opposite intended effect of increasing stigma in terms of perceived dangerousness, social distance, and the fact that people with a biogenetic disease or disorder cannot get well. So unintended, increasing stigma as opposed to decreasing it, while decreasing blame, which is kind of the intention. What about neurobiological? Remember, this one is about cause, this one is about impact and controllability. What about if we emphasize the neurobiological aspects? Does that help? Well, it turns out in the mental health field, this is a meta-analysis of the mental health field, they found that it had no effect on blame when emphasis was neurobiological emphasis was emphasized. Excuse my language there, and it actually found that it increased social distance, perceived dangerousness, and prognostic pessimism. That is to say, that people who have this neurobiological deficit or impact cannot get well. What about addiction? We just finished this study. It was a nationally representative study. What we wanted to look at here was the impact of different terminology. These were 6 different ways of describing the disorder itself. So we're not describing a person with a disorder, but rather the disorder itself here. And each of these 6 terms were embedded in a vignette, which was randomly assigned to roughly 300 people each of the general, 600 people each in the general population of the United States. This was a nationally representative sample. Now, I did that because I wanted to look at general public attitudes towards exposure, the way we communicate in policy and in our clinical work. What impact does that have on people's attitudes and perceptions of the nature of this disorder? And so I had these 6 terms. Now, a priori, before we did the study, I thought there was a gradation here in terms of the impact, the reduction in stigma that might occur with greater to lesser medical emphasis. So I anticipated that chronically relapsing brain disease would be the most medically oriented, the most heavy duty kind of medical orientation, followed by brain disease, illness, disorder, and then describing it as a problem. And what I did was create a vignette which described someone in treatment who was being taught that his or her problem, the person was left open, his or her name was Alex. And we actually split it, half were described as a woman, half as a man. But we looked at this person in treatment was being taught by treatment staff about the nature of their condition as being one of these 6 different things, okay? So at random, people would get this vignette, but with one of these terms embedded in it, okay? So it was between subjects at random. And what did we find? Well, very interestingly, similar to the mental health studies that have been done, we found a very positive effect on reducing certain types of stigma and a negative opposite effect on other kinds of stigma. In fact, as I anticipated, the effect on reducing blame, as was found in the mental health field studies, is that the more we emphasize the biological causes of substance use disorder by describing it as a chronically relapsing brain disease, blame goes down. In contrast, the perception that people can recover from a chronically relapsing brain disease also goes down. Their perception that that person is dangerous, that that person should be socially excluded, goes up when we talk about it in more biomedical terms. In contrast, you see over here, when we talk about it as someone having an opioid problem, the perception of prognostic optimism goes up, and the perceptions of that person being dangerous and should be socially excluded goes down. Now, what does that suggest? It suggests that there doesn't seem to be one single medical term that can be used to reduce stigma in all circumstances. For example, to reduce stigmatizing blame, it can be helpful to use this kind of biomedical terminology. This can be helpful to help people access treatment, for example. It might be helpful to use that terminology when we want people to access treatment. On the other side, though, when we're talking about reintegration into society, we might want to drop the medical terminology and talk about it as an opioid problem or a substance use problem to help increase inclusiveness in society, downgrade perceived dangerousness, and increase the likelihood that people can, and of course we do know they do, get well. So the last thing I'm going to talk about is language also, but language as it pertains to individuals who suffer from substance use disorders. And this is another third dimension of the ways that we can address stigma and discrimination. Now, there are lots of terms in our field that pertain to substance use, as you can see here, and people who suffer from these conditions. We've all heard these terms, some more pejorative than others, some are more clinical than others. Here's a question I often pitch to audiences. People with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as drug abusers or substance abusers, alcohol abusers, and not as having a substance use disorder? There's a discrepancy there, it seems to me. I've never heard anybody with an eating-related problem being described as a food abuser. It's always referred to as eating disorders, the eating disorders field, and eating disorders in terms of diagnostic nomenclature. Now, until very recently, now we have shifted in DSM-5 to substance use disorder, and there's a reason for that. Now, as I mentioned, we've learned a lot, and I think the nature of the disorder is clear. If this was not a disorder, if there was some aspect of people choosing to do this to themselves. Yes, they do choose in the beginning, but once the disorder onsets, there's a gradient of impairment in control, which results in what we see clinically and in society, is this impairment in the ability to control the impulse to use drugs, which results in roughly, on average, a shortened life expectancy of 30 years relative to people who do not have the disorder. So there is definitely a medical malfunction which happens. This is why, of course, it is a psychiatric illness, why it is classified as a psychiatric disorder, and has been done so for many, many centuries, actually, if not decades, from a diagnostic perspective, clinical perspective. But does it matter? I've shown you already that big study we did in the general population looking at the way that we describe the disorder itself. But what about if the way we describe people who suffer from it? Is it just political correctness, or is there something more to it, as we found in this other study? Well, we did these studies actually a little while ago now, but the question in my mind at the time was exactly that. Does it matter how we refer to people who have a substance-related problem? Because the abuse terminology in particular, which I still hear in certain quarters being used, and particularly in certain parts of the country, this describing someone as a substance abuser, what does that convey? What might that implicitly evoke in people's minds? I think it might evoke this idea of willful misconduct, because that it is their fault and they can't help it. They're abusing the substance. They're choosing to abuse it to get high, and so this is the implication with that terminology. Now, if you contrast that with terminology such as having a substance use disorder, it does imply, with the term disorder, of course, that there is some kind of medical malfunction. When we did our first randomized study, it was actually among doctoral level clinicians. So these were people with MDs and PhDs who were working in the mental health and addiction field. And at random, they received a vignette describing someone as a substance abuser or as having a substance use disorder. Otherwise, they were identical, similar to the other study I showed you. And what did we find? We found that when the person was described as a substance abuser, those clinicians who were experts in mental health and addiction were susceptible to the same biases as the general public. They were more likely to view someone described as a substance abuser as more to blame, less in need of treatment, and more in need of punishment than somebody, the identical person, described as having a substance use disorder. So it does matter. What about the general public? Again, these were even bigger differences in a similar study we did in the general population sample. Again, contrasting, describing someone as a substance abuser versus having a substance use disorder. And look at the magnitude of the differences here in terms of likelihood of treatment, likelihood of punishment, being a social threat, being to blame, and being able to self-regulate their abuse. That is to say, that they really do have control and that they're engaging, therefore, in willful misconduct. So in these, and this has been replicated by Rob Ashford and colleagues at the University of Pennsylvania, looking at implicit bias as well. Is it both explicit and implicitly biases people towards more punitive judgments, even when we don't intend it, even when we don't mean anything by it, when we use that language. Implicitly, it seems to trigger these kinds of schema, which are more punitive, more harsh, more judgmental in a negative way, towards punishment, again, towards the older policies of the war on drugs. Now, we didn't do a study on this, but we wrote a paper on it. Sarah Wakeman and Richard Seitz from BU. Sarah Wakeman works at Mass General Hospital as part of our substance use disorder initiative. In part because we hear this this kind of language used in our clinical settings, that people's urine toxicology screens are described as dirty or clean. We don't use that kind of language in any other area of psychology, social work, medicine, nursing. Only when it comes to substance use do we use words like dirty. This should not be, in my view, a part of our clinical verbiage lexicon in any way, shape, or form. So what do we need to do? I think shifting our language, again, that's one of these three elements: education, this social exposure, and language change. And this has really started to happen, that we started to use person-first language, which was started in the mental health field a long time ago. We're starting to use person-first language now as part of our vernacular, and to prescribe it more because of the science base that we have now, to actually eradicate the term abuse and drug abusers and alcohol abusers and opioid abusers out of our lexicon. We published a dictionary, trademarked it, and published it several years ago now. But I think if we want addiction destigmatized, we need a language that's unified and that also accurately reflects what we have learned about these conditions over the last 50 years, both in terms of cause and controllability. And this dictionary now has been adopted by Google, by the American Bar Association. We went to Budapest a few years back and spoke at the International Society of Addiction Journal Editors, who adopted a consensus statement to eradicate, to recommend not allowing across the world scientific literature that we should exclude language like abuse and abuser because it's found to be stigmatizing. Get it out of our lexicon. Journalists also have adopted the APA Style Book in 2016, adopted and advocated for non-stigmatizing language to be used among journalists. Of course, this is where most of us get our information. So if journalists start to change their language, this has a major impact on our overall cultural psyche and language. Another thing that we need to do, we're trying to do right now, is to change the names of the National Institutes of Health, which pertain to addiction. That is to say, the National Institute of Drug Abuse, the National Institute of Alcohol Abuse and Alcoholism, and the Substance Abuse and Mental Health Services Administration, and the Center for Substance Abuse Treatment. You just heard me say abuse 8 times there. There are 4 types of people in the world: those who can count and those who can't. I didn't say it 8 times, I said it, I think it was 5 times. But anyway, if you're counting. But the point is that the term abuse is still embedded in our National Institutes of Health. And of course, this is it undermines, in my and many other people's view, undermines our overall public health impact and approach because these names are still embedded. Now, it just takes a matter of political will and the people's effort for us to actually say, look, it's time for change. We need to get rid of these names. It's been found to be stigmatizing. Ironically, these institutes are promoting public health efforts, of course, to diminish stigma. And you cannot find a person in these institutes who think that the term abuse is a good term to use right now in these names of these institutes. Now, we have created a petition, and we're working with different stakeholders, constituencies around the country, and political, in terms of politicians also, to try and get these names changed. We have this petition to do that, to try and change the names. So if we speak up, if we're the squeaky wheel, I think we can change these names, get rid of these names, find new names which are non-stigmatizing, and that will have a major impact, I think, overall in terms of recognizing the importance of addressing our terminology and language as it pertains to stigma. So in clinical settings, as I mentioned, clinicians also and clinical systems are susceptible to the same kinds of biases as other people in the general public. What can we do to reduce stigma in clinical settings? Well, I think we can advocate for, prescribe, model, and reinforce universal clinical use of appropriate person-first, non-stigmatizing terminology pertaining to alcohol and other drug use disorders and related problems. And I think that's very important, to shift our language, to emphasize the importance of how we speak about things, both reflects and affects our approaches to them. Provide continuing education on the nature, the causes and impacts of substance use to clinical leadership, to practitioners, and to all staff who are interacting with people right at the front desk, who may not be a clinician, but to get those individuals as well trained and understanding about the nature of these conditions. And also to emphasize the importance of addressing substance use disorders at the clinical level, ethical, humanitarian, compassionate care grounds, as well as health economics. We know that addressing substance use disorders more effectively drives down healthcare costs These are major contributors to the healthcare cost burden, as well as other kinds of economic burdens. Provide regular opportunity for interaction and exposure to recovering persons to help dismantle stereotypes, and as I mentioned, disabuse that of faulty beliefs that they may hold. And related to that is to create a recovery-friendly, and I'm working right now with the government to look at this issue of workplace and recovery-friendly workplaces that openly and continually support treatment and recovery for employees who suffer from SUD, and including employment of individuals with SUD histories. And these are some of the ways I think that we can address stigma in clinical settings more effectively. And with that, I want to thank you very much for hanging in there with me and for coming today. We have some time for questions. You can put these questions in the chat or actually just speak them out loud if you unmute yourself. Thanks so much. Is there any questions in the chat, Ting-Yi, or any other questions that people want to ask? Feel free to ask if you want to unmute yourself.
Yeah, so we have one question from Angela DeSantis. Are you aware of any research that studies structural or functional changes in the brain caused by substances commonly found in mass-produced food products, examples like caffeine, processed sugars?
I think there are studies on sugar, processed like high fructose corn syrup, things like that. I'm not sure if it's preclinical or clinical studies, but I think there are studies showing the functional changes in the brain. I'm not sure about structural changes with regards to things like that high density, high potency sweeteners that have infiltrated the food supply in every way, shape, or form. Again, the toxicity in these changes are in the dose, so it depends on the amount. And typically in those preclinical studies, there tend to be high exposure to those sweeteners. But I'm not an expert there, so I don't want to go too deep into that.
Right, and then we have another question about drug courts from Melissa Weitznar. So aren't drug courts being renamed to use less stigmatizing language?
Yes, there is movement. In fact, I was just on a panel last week. There was an expert there on drug courts, quote unquote. I can't remember what the new nomenclature is. Forgive me for that. But there are shifts within drug courts, of course. And I was speaking to the New England, the New England judges about a month ago, Ting-Yi, wasn't it? We did a presentation for them on stigma and discrimination and kind of treating addiction as chronic illness. So again, the world is in constant motion, constant change. There is a movement. It's not universal. It's regional. It's subcultural. But there is a movement, I think, which has started a long time ago. As I've mentioned, there has been this gradual shift towards these broader public health approaches. Again, as we've understood more about the biomedical nature and impact of substance use and substance use disorders, that has led to this greater emphasis on using the criminal justice system really as just a doorway into treatment. Hopefully that we can start to do that. And as I mentioned, we've seen that both at the front lines of law enforcement all the way through the criminal justice system. And I think that's just going to be amplified, emphasized more as we start to look at it, and particularly the best models, practice models of doing that, so we can help people better.
Amazing, thank you. We have a question from Roxanne Newman. You want to go ahead?
Hi, Dr. Kelly. Thank you so much for your presentation. I always learn so much every time, something new. So I do have two questions, but I'll just ask the most important one. Then if there's time after, I can ask the other one. Do you think it's worth investigating what people who have been open about their recovery status, the benefits of doing so? I think that a lot of the research concentrates on the negative aspects of stigma and what that looks like when people talk about their substance use disorder. But as a person in long-term recovery and a very vocal person at that, maybe a little too vocal sometimes, I have found that while not knowing what it has not, what it has, how it has hurt me, I find that it has helped me tremendously in ways that I could have never imagined, both academically, career-wise, and just so many different ways. And I don't think we hear that so much.
Well, you know, that's a great point, Roxanne. Thanks. Good to see you. Thanks for the question, and thanks for coming. Yeah, you know, right on. You know, I mean, this is a fairly ancient principle, right, of kind of being, you know, it's kind of like that idea of the helper principle that's embedded in mutual help organizations. When I help somebody else, it helps myself. And of course, the intention is to, you know, help others by being a model of recovery, but it also helps the person who's disclosing. And I don't think that's, I haven't seen any studies that have looked at that, but what a great idea, right? To look at that, how that actually impacts the person who is disclosing. That would be, I think, very important to study and get out there to understand that, because I agree with you. I think that it's likely to build one's own self-esteem and self-efficacy as one does that, as you pointed out and as you have experienced. So, but you know, it may be variable. Who knows? It depends on, I guess, circumstance and when people do it, et cetera, and to whom, and what capacity. All those things may co-vary with that impact. But what a great idea to actually look at that.
Well, don't forget about me if you do it.
Okay, for sure.
Well,
Yeah.
to build off of that, if I may, I'm also a person in long-term recovery, and when I see these studies you presented, they're fantastic. But there's one was addressing general population, the other one mental health clinicians. But has there been anything that speaks specifically to people in recovery and what they find stigmatizing?
There have been, yeah. Thanks for the question. Yeah, there has been. I mean, there's been lots of smaller studies that have been done, qualitative studies, less systematic studies that have been done to understand how people in recovery or suffering from substance use disorder, how they want to be referred to. So there's been a few qualitative studies in those areas, but I think there's more, definitely a lot more room for, I mean, you know, there's very little systematic research in this area, but a few, you know, a few qualitative, there's much more room for investigation there to understand both people in recovery, people who use drugs, and their family members to understand more about their own preferences for how they're referred to, for example.
All right.
Thanks for that question. Yeah.
I think we just have time for one more, so we're gonna go. I mean, thank you for everybody writing in the chat. I'll make sure Dr. Kelly gets those questions, but we'll go to Ruben Handler, who has their hand up.
Thank you. Thank you so much, Dr. Kelly, for your talk. You started off by reflecting that this is 50 years since the beginning of the war on drugs. And I'm curious if there's research on how efforts towards decriminalization or legalization of substances have impacted stigma in Portugal or other places that have made efforts towards that.
Yeah, I haven't seen studies on the impact on stigma. Thanks for the question, Ruben. It's a great question. Yeah, and you would think and hope that that decriminalization, which I think is probably the way to go, which now Oregon has just passed, of course, laws of decriminalization, which means you don't get a criminal record for possessing, you know, which can be a major barrier for people when they want to get into recovery. As I mentioned, that building permit that people need, they're deprived that because of this criminal legacy related to drug use. So when you decriminalize personal use for personal possession, that has a major, I think, a major positive impact. And it also, as you're alluding to, may have a broader ripple effect in terms of diminishing the public stigma around these conditions. Because obviously it's sending a message that we need to do something different, that people don't need to be criminalized, but rather they need to be helped through treatment, hopefully. Thank you. Yeah, I'm sorry we don't have more time for questions, but I will try to answer your questions in the chat. If you also want to email me, feel free to do that. And I'll try to, I can send you any of these slides, the papers. We will have the slide presentation recorded, of course, and posted for your re-reviewing anytime, sharing it, as well as the slide set. I can send you PDFs of any of the papers. So please reach out if you would like any of that. And thank you all for coming today. I really do appreciate your interest in this topic, and let us know if we can help.
Thank you.
Thanks, everybody.
Take care.
Thank you.
Take care. Have a good afternoon.
You too.
Thanks.